Hi, everyone. My name is Haley Ingersoll, and I'm a health experience research consultant and current policy fellow with the Network for Social Work Management. It's a pleasure to be with you all this week and taking part of the Forward Thinking Summit. Today, I'll be sharing more on my experience working with patient narratives for healthcare improvement. But before I start, I just wanted to take a moment to hold some reverence for you, the listeners, and your resilience, for the lessons, grief, transformation, hope, and everything in between that we felt from the onset of the pandemic to now. I'm very glad that you're here, and I'm very grateful for your time and attention today. One thing I've learned in all of this is just how sacred and valuable that time can be. And I'm honored that you've taken it here to spend it with me today, talking about an often sticky and ugly issue, that is healthcare. Yet it's one of the most timely and inevitable subjects that we can be discussing, especially if you're tuning in from the US, where we know well that healthcare is a complex patchwork of public and private and nonprofit versus for-profit. And this is all of these systems have had their trials and hangups during the pandemic. Few things have done a better job showcasing the interconnected nature of people, organizations, systems, and the world as a whole. COVID has also pulled back the curtain on many inefficiencies and inequalities across the board, but we need to be clear that it did not invent them. This is especially true when it comes to the healthcare system, which many have already known to be expensive, fragmented, and difficult to navigate. And I can tell you this, we have our work cut out for us, but fortunately, that revelation and recognition allows us to find clarity and insight and ideally a path forward. I decided to call my talk What Words Convey because I'll be sharing about the impact of patient narratives and person-centered values in healthcare. And to start with that, I want to frame the differences between value-based and fee-for-service. Truthfully, we could probably spend several lifetimes talking about this and trying to make the healthcare system more coherent. But for our purposes today, I'm going to keep it as simple as possible so we can stay sane. So without further ado, the fee-for-service model is one where doctors and providers are paid for each service performed, and these costs are determined through various processes affiliated with the respective public or private insurance company that the system is affiliated with. It's beyond my pay grade to explain this in much further detail, but I will tell you there's a lot of great podcasts on it. What I'll need you to know for today is that this incentivizes providers to bill for more services, whether they're needed or not. And this often is not great for patients or their wallets. And before it sounds too much like I'm poo-pooing fee-for-service, it's important to note that this could be an excellent model if costs were low. Unfortunately, this model usually tends to increase inflation and redundancy. And as I said, a lot of times it allows for providers and hospital systems to make a buck on it. Value-based tends to center quality over quantity, cost based on value to patients and historic prices. It can also lower the cost of care, tends to be favored by Medicaid and Medicare, and incentivizes providers to work for quality outcomes. It's important to note, too, that these two models are not mutually exclusive, yet the US healthcare tends to trend more toward a fee-for-service model because we live in a capitalist society where we like to make money. In recent decades, there's been growing demand for patient-centered care. In patient-centered care, an individual's specific health needs and desired health outcomes are the driving force between all healthcare decisions and quality measurements. Patients are partners with their healthcare providers, and providers treat patients not only from the clinical perspective, but also from an emotional, mental, spiritual, social, and financial perspective. In a more value-based system, there's attention paid to long-term cost savings in the form of good nationwide health. Profiting off of sickness is a symptom of a much larger disease, and that is lack of compassionate, person-centered care. And when I talk about these models, I'm really not hoping to create a false dichotomy or favor one method over the other, because the truth is, if costs were low when it came to fee-for-service, it might be a genuinely great model. And also, it's important to note that both of these are currently employed in the healthcare system. Providers use them across the board, and they're often being modified and tested to improve patient experience, but adaptations tend to be slow on both fronts. And we know now that it's no time to lack urgency. As I named earlier, we have work to do when it comes to improving access, cost, and quality of care. And it's clear that doing things the way that we always have really isn't going to cut it. It's time to think boldly and act boldly. And that's why I'm here to share the individual and organizational benefits, as well as the cultural imperatives of centering patient experience in healthcare improvement. The utility of patient experience and patient narrative is absolutely essential to moving toward a more value-based system that centers the humanity of individuals and their dignity and worth. Narratives about patients' experiences with care are essential for value-based quality improvement because they convey actionable information that both elaborates on existing domains within the healthcare system and describes additional domains that are important to patients. This helps convey ample actionable info for improving practice and centering patient experience in a way that helps them feel valued. At the heart of this work is a belief that patient experience is not one size fits all. Patient point of view covers a wide array of experiences, cultural differences, communities and environments, family medical histories, and so many more variables that are rooted in social determinants of health and well-being. In brief, the work that I do as a health experience researcher includes coding narrative survey feedback for patients across 20-some clinics in an ambulatory hospital system. We utilize a coding scheme that is modeled off key domains identified by patients, ranging from cleanliness of facilities, access to care, communication, care coordination, relationships with clinical staff, and more. Patients are given surveys asking a series of open-ended questions that aim to elicit more generative and expansive responses. These responses are then coded accordingly and forwarded back via reports to the health administration, clinic, and providers to inform their practice. This offers a value added to the practice as they get direct feedback on what is going well or what can be improved, and it also indicates to patients that their experiences and viewpoints are valid and essential to the quality of the practice. Needless to say, the implications of such rich narrative data can be powerful on the individual patient and provider level, but also inform clinical efforts at the organizational level. This is important because it reflects a value-based mindset and approach that genuinely values patients and ultimately leads to better costs and better health outcomes down the road. So on the slide here, I have an example of one of the questions that can be found on the survey that's provided to patients asking, when you think about things that are most important to you, how do your provider and the staff in his or her office measure up? And the second is what might be a typical response, basically disclosing that the patient was unhappy and naming exactly why that is, including front desk staff being unfriendly or unhelpful or ignoring them, and a waiting area that was either crowded or unclean, or a doctor that didn't really feel like they spent enough time with them or gave them the time of day. With these narratives, then we apply codes that reflect this negative valence, basically saying that I had a negative experience when it came to the quality of my care, or that a receptionist was unfriendly. And there's actionability codes that we can assign to that as well, to assign directly back to hospital admin, front desk, custodial, and medical staff, so they know exactly what went right or wrong in that care experience. As we move toward pandemic recovery, there are serious considerations for equity and quality improvement moving forward. I can't emphasize enough how much the COVID experience has been illustrative of what's just simply not going right on the systems level and individually. And for that reason, we've begun coding and collecting anecdotes related to the COVID experience to ideally capture what it was like to be a patient at this time, what the hospital system did right, and where they can improve going forward. So with that, we've started collecting COVID data related to emotional implications, practical implications, general references to the pandemic, as well as safety, including PPE or social distancing measures and temp checks and so on. So far, this has given us a very candid line of sight for what it means to be a patient at this time and what the healthcare system looks like. Some examples include patients who have postponed critical surgeries multiple times for fear of either getting further sick or hopes that the pandemic might blow over, or other patients have remarked about the emotional implications of having a provider who just appears more stressed out or spread thin. And some of them are positive reviews that the waiting room hasn't taken as long, or they really appreciated as an immunocompromised person that they just stayed in the individual examination room and were seen only there to limit exposure. Furthermore, we've added an innovation code that assesses a patient's hopes and dreams and gets them to think a little bit more aspirationally about how care could be improved. The question is below, where it says, if you could, what would you change about your care or interactions with your provider and his or her staff? Hearing from you is important to improving the care that we deliver. This value statement alone lets the patient know that they are valued, and it also gives them the space to share what they think could go right. This will be important as hospitals begin to dust themselves off and think about the road ahead. Of note is that we've also started collecting patient experience related to telehealth as a clinical tool. And I think this will be a really important part of the conversation moving forward of what role telehealth plays to patients and how quality can be improved in that front, because it's becoming clearer than ever that telehealth is ultimately another leg of the stool that is the healthcare system, and in a lot of ways can boost accessibility and patient rapport and relationship. Our hope is that these insights can be disseminated and woven into practice and ultimately shape the way that we view patient experience. Finally, like all good talks, I'll leave you with a 3-point plan for transforming healthcare at the individual and organizational level. 1, recognize the organizational value. Know that value-based care not only helps health in the long run, it boosts patient morale and engagement, informs clinical improvement, and ultimately saves costs. What's not to like? 2nd, consider the cultural imperatives. There are serious equity considerations for providing affordable, accessible, quality care. We've seen this with vaccine rollout, how beneficial it is that everybody has access to proper, comprehensive, proactive health care. And our present collective health and social prosperity depend on this, as do our long-term life expectancy and quality of life. It just makes sense. 3rd, commit to fundamental change. The demand for patient-centered care is on the rise, but frankly, it never really left. Relinquish limiting ideas around feasibility and act boldly to uplift lived experience. Transformation will not happen passively. Cringy pun intended, and I said this already, but Band-Aid solutions are not going to fix this. We now know more than ever that we need to act boldly. Centering patients' unique experiences and leveraging their insights and expertise is a proven value added for providing care that is informed, empathetic, and ultimately grounded in quality as patients themselves see it. This could not be more important as we dare to imagine a world that is more equitable, inclusive, and just. And as social workers, we understand that meeting people where they're at, treating them with dignity and worth, and just ultimately respecting and being mindful of their humanity is a lifeblood of the well-being of our society as we know it. With that in mind, I hope I've made the case for using patient narrative for quality improvement at the healthcare level, but also for better centering client experience, patient experience, and most importantly, humanity first across all disciplines that we're in and where we find ourselves. As social workers or practitioners of any kind, it's really important that we put the people first and profit or our own ego second. And in closing, I'll leave you with the following quote: "Good words are worth much and cost little." You can find more work from the Health Experience Research Network at healthexperiencesUSA.org, or I'd gladly connect with you and share a little bit more about what I do as well as my colleagues. I really appreciate your time and thank you for listening today, and I hope you all take good care.